Well, let me go back over here. All right. All right. So good morning. And so today we're going to talk about acid base. Good old acid base. Did everybody have a chance just to kind of breeze over it a little bit? I know Barker said he did. We were talking before everybody kind of logged on. Anybody else?
I watched a few Ninja Nerd videos on it.
Okay, good. Ninja Nerd's awesome. So, all right. So let me flip over here to the whiteboard for a second. All right. All right. Just some review before we kind of get into this when we talk about the chemical control of breathing. So everybody understands that the brain, right, as that respiratory center of the brain, and we have those nerves or sensors in the brain that monitor CO2, right? And so what's the name of those again?
Chemoreceptors.
Absolutely, chemoreceptors, right? And we know that these chemoreceptors, your book calls it partial pressure of carbon dioxide, but we just say it reads CO2. So I didn't want that to confuse anybody, right? So it reads CO2. And what else do these chemoreceptors read? Do they read O2?
Yep.
Yes.
All right. And there's something else that these chemoreceptors read that we're going to talk about here very shortly is they also read hydrogen. All right. And so that's the book tells you that the chemoreceptors read a pH, right? They do that by sampling cerebral spinal fluid, right? So they read O2, CO2, and hydrogen, right? But it's reading that hydrogen ion that they're able to start reading pH through that. I'll explain in a second. So anytime that you guys this is a hydrogen ion. What this really means is acid. All right, so anytime you see a hydrogen ion, I want you to think acid. And so how would we define what an acid is? Very good. All right, so an acid is a substance. Okay, it's a substance that increases hydrogen ions. Okay. And they call it in a water solution. So plasma is mostly what?
Water.
There you go. So an acid could be defined as a substance that increases the hydrogen ions in a water solution, or in our case, in blood. All right. So that's the first definition. So remember that the term homeostasis, right? Well, anytime you have something like an acid, you need something that can neutralize it, maybe. So we come up to the word base. And so what do you think the definition of a base is?
Less hydrogen in water.
Absolutely. It's going to be the opposite of that of an acid. So this would be, a substance that decreases that hydrogen ion. All right. So not too hard yet. Pretty simple terminology. Yeah. So if you have something that produces more hydrogen ions, you got an acid. If you got something that reduces that, you got a base. So when we look at the blood, all right, so we talk about blood. Blood in this case, then, since it's mostly water, is it fair to say then it could be acidic? So there could be too much acid, too much hydrogen ions, or it could be the opposite. It could be too base, have too much of a base, right? So it could have a way reduced amount of hydrogen ions. And so how then, in this case, if we have this acid and base that we're talking about, how do we tell if it's got too much acid, or how do we tell if it's got too much base? What is the unit of measurement? How do we measure it?
pH scale.
pH.
Absolutely. That's pH scale, right? So good old pH scale. Sorry. Wow. Everything on my desk is all crooked. I can't draw a straight line. Okay, hang on a second. All right, so here's our pH scale. All right, so we got a 1, a 7, and a 14, just for an example here. All right, so again, I want you guys to think like, and this may look normal to some folks, but the way it works is the person who did this, I think, was dyslexic. Because if you have something that's very acidic, it's going to be down here on the low end of that scale. But if you have something that's got a lot of base in it, it's going to be on this end of the scale. And so blood normally, for it to be neutral, for it to be exactly where it needs to be, it needs to be 7.35 to 7.45. That's the normal range for the blood scale. And I was doing that 1 o'clock yesterday, and Mays brought it up. He said, does that correlate with CO2 readings like 35 to 45. And I don't think it does, but it's a good way to remember the blood number. 7.35 to 7.45 is normal. And that's something you do need to remember. So to give you an example then of what's acidic, well, is it, the acid found in the stomach has to be very acidic, right? Because it has to digest food and stuff like that. So stomach acid is usually somewhere around like 2, maybe 3, somewhere like that. All right, so that's around your stomach acid. So the higher you go in this, the more basey you get. And so like over here, you may have somewhere like, they use like mineral spirits to clean concrete with, right? And that stuff's bad. I know some of you guys know what I'm talking about. As soon as you pour that stuff out, man, or sulfuric acid, as soon as you pour it out, it's smoking. As soon as it contacts air, it's smoking. It's bad stuff. You gotta wear gloves, all the other stuff. But the more basey things get, it can be abrasive too. People clean with stuff that are very basey to get similar effects with acid. And so like over here, you may have like baking soda, something very basey. Okay. So that's how we're going to kind of decide if we did a blood test and we wanted to check somebody's pH, we could draw some blood and we can look and see. And so then we can decide whether the patient maybe is acidic or maybe they're alkalotic. All right, so that's kind of how that works. So let's talk about how we're going to start applying this. So do you guys remember when I said anytime you have an increase in CO2, what will you have if I'm retaining CO2, if I have an increase, am I going to have more acid?
Yes.
You remember that?
Yeah, it'll be more acidic.
Absolutely. So let's look at that for a second. All right, so as an example here. So let's say that if I have an increase in CO2, what does my pH do?
Drops.
Absolutely, because I'm becoming more acidic, right? All right, so what happens then? How does my body compensate for it ventilation wise? What's going to happen to my respiratory rate?
Goes up.
Oh,
Has to, because I have to blow off that CO2 in order to get rid of that acid. All right, so let's look at this though. What if I'm breathing really fast and my CO2 level drops? What's going to happen to my pH?
Goes up.
Goes up. Right? Because I'm not blowing off that CO2. I'm retaining it now. And that's going to help me, right, to become more acidic, and that's going to help to increase my CO2 level. So respiratory rate in this case, what would it do?
Slow down.
It
Slow
will.
down.
Has to. All right, very good. So we're there with that. That's good. All right, so What's some disease processes you think then might I be looking at that would cause me to become more acidic?
Cancer?
Not so much cancer, but possibly
Asthma.
Drug
Yes.
overdose.
asthma. Yes, absolutely. we
Congestive
have
heart
asthma,
failure.
a drug
COPD.
overdose. Why? What in this case? Why would a drug overdose make me more acidic?
Because their breathing is it's
That's the big
slowed
thing. I
down.
want y'all, right. That's the big thing I want you to understand. And that is probably breathing. If I'm not breathing very fast, then my body can't rid itself of CO2. Right. But there is also something here that I'm going to introduce is metabolic. So there may be something besides the respiratory rate, something medical, or in this case, metabolic,
Diabetes.
that could change to make me more acidic, or could make me more alkalotic too.
Diabetes.
Diabetes would be an excellent example of what I'm talking about here. A diabetic, and we'll talk about that. Okay, so those are just some that just kind of gets you to thinking, about what some of the things that can cause that. So anytime you have something that causes you to be more acidic, because you're not breathing well, right? Or maybe you're breathing too fast. Anytime something because of breathing, whether you're breathing too slow, it makes you acidic, or you're breathing too fast, it makes you alkalotic, right? That is going to be called respiratory acidosis or respiratory alkalosis. Okay, so anytime your breathing is affecting your pH, right? So in this case, right, to be acidic, we have a high level of CO2 because we're not breathing well, right? Our respiratory rate in this case, whoops, I don't mean to do that. Our respiratory rate in this case is going to be probably fast. Okay, and so that's going to make my pH drop. With alkalosis, right, respiratory alkalosis, what's an example of when somebody's breathing really, really fast?
When someone's going into shock.
No, I was thinking, what about a psychological disorder?
They said low respiratory. Okay.
Anxiety.
Anxiety, right? Hyperventilation. So in this case, respiratory alkalosis, you could have somebody who's hyperventilating. All right. So in this case, we have our CO2 levels are dropped. We need to lower that respiratory rate. pH is usually high, right? Because we're alkalotic. Remember, 1,715. Here's your acid down here. Here's your base up here. Right. So we have somebody then whose alkalosis they're going to be up here. So, you know, somewhere up here, we need to reduce that. All right, so let's get into the fun stuff. So the body manages this pH level, right? Let me just put it right here. 117. All right, so the body manages this pH level through something called a buffer system. Can anybody tell me what a buffer system does?
Just keeps it from going too far from what it's supposed to be. Keeps the body's pH from going too high or too low.
Okay, so yeah, so when you think about a buffer system, what you want to think about is something that's going to keep the homeostasis, right? We want to keep it not too hot, not too cold, just right. So we have it's going to be a compound that's going to neutralize. All right, excess acid. Okay, not just excess acid or excess base, right? Because we want to keep it just right. All right, so this is going to keep that pH level at a good rate. All right, and so remember it's hydrogen, right? So remember this is acid. All right, so we need something then that can manage acid. All right, and so let's talk about how this works. Okay, so bear with me, please. I wish I was on a real whiteboard here, but I'm not. Oh, this is just not going to work. Hang on. All right, so we have. All right, so you guys remember we got the alveoli. This is going to be very crude. I'm so sorry. All right, and so we have the alveoli. Let me just draw the the circuit that we used before. All right, so here we go. Remember that we have the vessels here. And if we take our heart here and put some structure to that. So we have the right atrium. All right, so we have blood that's coming back to the right atrium. All right, it goes through the tricuspid valve into the right ventricle, right? Then from the right ventricle through that pulmonic valve, right, through the pulmonary arteries, and then up here to the alveoli. All right, it's going to exchange what? It's going to exchange that dirty CO2 for what?
Oxygen.
Oxygen.
Oxygen rich.
Exactly right. So here, right, we're going to get rid of CO2 and hang in there with me. We're going to pick up O2, right? And so we get these nice, oxygenated red blood cells now that's going to travel back down here to the left atrium. It's going to go through the bicuspid valve into the left ventricle, right? Out the aorta. Right, and then goes down here, right? And so, one second. We have our oxygenated red blood cells here. And that same process, is going to, same thing's going to happen. We're going to have our, remember we have our cell here. Whoops. And we're going to say, please let me have that O2. And I will give you, in return, CO2. Okay. So I wanted to take you back to that because we need to see it. All right. And so what we're going to have here, then, if we look at this, we have CO2. Okay. Now, when we're talking about the blood, what is blood mostly made of?
Water.
So can we call water H2O? So if CO2 plus H2O. All right. So that's kind of where we're at right now. Let's add these up and see what we get. So let's start with hydrogen, because that always kind of comes first. How many hydrogen do we have here?
2.
2. Okay. How many carbon do we have?
1.
Okay. H2C. Okay. And how many oxygen do we have?
3.
That's right. This little 2 makes that oxygen 2, just like this hydrogen right here makes it 2. And we can't forget to add this hot oxygen here. So that is going to be H2CO3. Would you believe me if I said this actually has a name? And it's called carbonic acid. It's an acid. Well,
So when CO2 and H2O mixes, it's carbonic acid.
yep. It's called carbonic acid. And so when you think about it, you go, well, just pure damn it. I mean, it's got to be bad. It's an acid, right? Well, yes and no. Because carbonic acid is known as a weak acid. Okay, it's weak. It's a weak acid, and they don't define that weak acid by its potency. You know, they don't say, well, I mean, carbonic acid doesn't eat your skin off. I mean, it may, you know, do this, that, and the other, but it's not going to hurt you. You know, that's not how they look at it. What they do look at it is from a chemical standpoint. How well can this hydrogen, when we're talking about this hydrogen right here, make a different color. How well can this hydrogen, because there's 2 of them, how well can they hold on to each other through bonding? How well can these 2 hydrogens stay together? And in this case, when it's H, 2 H's and 1 O, he doesn't hold on to his brother very well. He's a poor babysitter. Very bad. He gives up that hydrogen very easily. But nonetheless, he still gets to call himself an acid, even though he's very irresponsible, can't hold on to his brother very well. He still gets to be called an acid. All right, then. So with that being said, let me get us some room here. But because he can't hold on to his brother very well, he gets another title. And this is a buffer. He gets to call himself a buffer. And let me tell you why. All right. Let's take this and let's say we have an increase in hydrogen. All right. So what then's going to happen is we have an H2CO3. We have a weak acid. So the buffer system, we have acid in the blood, and the buffer system's got to fix it. So what's going to happen is his brother is going to go break off. So he's going to lose his brother. And now, since his brother's over here, his brother gets a title. He gets to call himself now bicarbonate. Has anybody ever heard of Pepsid AC, Pepto-Bismol, Malox?
For the Pepto-Bismol.
Okay, Pepto-Bismol. What about Pepsid?
Oh, the pills
Yeah,
that you drop in water.
yeah. That that when you have you've been out drinking all night and you got indigestion the next day. You're like, oh my God.
Alka-Seltzer.
Okay, Alka-Seltzer. All right. I'll take that. What about Rolaids?
Yep.
Heard of Rolaids?
Got some of them in there. Heartburn, right?
Right. Does everybody know what it's like to have heartburn?
Yes.
All right. So
Yes.
if we look on the back of the package of Rolaids, it's going to have as an ingredient bicarbonate. If we look on the back of the package of Alka-Seltzer, it's going to have aspirin and it's going to have bicarbonate. Or it may even call itself sodium bicarb. If you look on the back of Pepsid AC, it's going to say, all right, what's it say on there? There's a man. Harris, what's it say?
This is for acid reflux. It's calcium carbonate.
Okay, carbonate. Carbonate. Very good. Pretty interested in it. So we know then that this will break down acid. And so that's how the body responds to acid. It says, okay, I've got too much acid. I'm going to lose a hydrogen. It's going to be by itself. I'm going to make bicarb to reduce the acid. All right, so let's look at the other end of this. Suppose I am alkalotic. I have a decrease in the amount of hydrogen in the blood. Okay. So hang on. So I am very basy.
So bicarbonate is basically like the filtration chemical compound, I guess.
What bicarb? Well, yeah, bicarb reduces acidity. Okay, that's what bicarb's job is. It reduces the amount of acid. So in this case, if I have a decrease in hydrogen ions, which remember, this means acid. And I'm very basy. So very basy. And I need some acid. So what's going to happen here is this hydrogen is going to pull his brother back in. And make carbonic acid again. All right, so now we'll add some acid to the system and we'll fix it. That is what's called a buffer system.
So if you give somebody bicarb
Mhm.
and they're already acidic, and that hydrogen ion binds to the bicarb and makes carbonic acid, wouldn't that just make a whole bunch of carbonic acid compound inside their blood? Like,
So-
why would?
Yeah. So it's all about, so if, let's say I have H2CO3. So I have carbonic acid here, and I'm very acidic. So I have an increase in hydrogen. And I'm going to give some bicarb. All right, so the more bicarb I give, the more it's going to affect this and take away this extra hydrogen. So if I give bicarb in this case, it's going to reduce the acidity. Okay, it's going to make this hydrogen up here give up that hydrogen more readily. That makes sense?
So
Sorta.
it'll basically just
But we're
take away,
remember,
or it'll dissolve.
yeah, remember
It'll take
that-
away that hydrogen bond and I'm
Mhm.
sorry, go ahead and start.
I didn't mean to interrupt
apologize.
you. I'm so sorry. No, I was going to tell you though, when you're thinking of this, remember our body's making the bicarb. In this case, we're not giving it. Our body's making it. But if we needed to give bicarb, and we did, it will reduce acidity.
Okay.
But the blood buffer is actually always jumping back and forth from either making carbonic acid or making bicarb.
Okay, got you.
Okay. All right, so let's look at the big picture again so that we make sure everybody's clear. Okay. All right, so right atrium, right ventricle, left atrium, oops. Ventricle. All right, so all right, so let's talk about, let's kind of try to put it together. So here's your brain. Here's your brain on drugs. All right, so up here, we know that what part of the brain is the respiratory center of the brain? Oh, come on, guys. Y'all, I know y'all know this.
The cerebrum.
All right, it's got the cool name.
Medulla oblongata.
Thank you very much. All right, thank you very much. All right, so Back here is the respiratory center, your cardiac center, right? And we're monitoring. Now we kind of understand why we're monitoring the hydrogen ion. We're monitoring CO2 and O2. All right, chemoreceptors. So chemoreceptors are found in the arch of the aorta and up here in the carotid arteries. Constantly monitoring O2, CO2. What is our stimulus to breathe? Why do we take a breath?
Oh, carbon dioxide level.
Right. If we have an increase in carbon dioxide, that's going to make us breathe faster. All right. So if the chemoreceptors receive a message that the body is becoming more acidic. So we have an increase hydrogen ions. So it's going to send that message over here. To the respiratory center, the brain says, hey, this is what's happening, right? So we know that the formula that we just talked about, CO2, carbon dioxide, plus water, yields the buffer system called H2CO3. All right, so we know this is called carbonic acid. All right, so these guys, all right, so our receptors up here are going to say 1. It's going to come down here and tell the diaphragm to do what?
Track.
It's going to tell the diaphragm to what?
Check on track.
Contract.
Yes, contract hard and fast. Because that's going to do what? What's that going to do to the respiratory rate?
Increase.
Yes, sir. Increase. All right. So we have an increased respiratory rate. Why? Because we need to get rid of CO2. All right. We need to drop that CO2. All right. So that's one thing that the body's going to do to fight this increase in acid. So we're going to increase respiratory rate. What's the buffer system here? What does it need to make?
Bicarbonate.
Absolutely. And so what's so cool about this? I need a little more room here to write this. Is this reactions, these are always going to be going right or left. Okay. It's always going to be going right or left, depending on the needs of the body. This reaction could go either way. Oh, my bad. So if we look at CO2 plus H2O, they kind of list this as the respiratory component. And the reason why that is because we talked about it. You know, we're going to, coming out of here, we have O2. And coming from the blood, we have CO2. So CO2, and think of the blood being mostly water, H2O, and your alveoli playing a role here. It's the respiratory component. This is known as the circulatory bicarb buffer. And the reason why that is because we talked about it. If this hydrogen, if I lose a hydrogen, I have bicarb. See, there's your hydrogen. It just disassociates, it separates, right? And so that's how the body deals with the circulatory bicarb buffer. That's how it manages that. This right here, we haven't talked about this yet, is known as your renal component. All right, so let's talk about it next.
You want to go ahead and take a break?
Yeah, let's do that. Let's take a break. Let's take 15 minutes and we will come back. And guys, if you're not getting this, it's okay. We'll do this until you do. So just relax, let your brain absorb it. Promise you will get it. Okay.
Mind if I ask you a quick question, sir?
Hang on a second. Go ahead.
Mhm.
So, right there where you wrote circulatory bicarb buffer. So even though that's carbonic acid right now in that, just where you wrote, it's still considered a bicarb buffer because that's what it'll end up being.
Looks like an antidote potion.
That's correct. It shows carbonic acid in that form that it is in, but that hydrogen disassociates readily,
Right.
easily. And so it could become either, it could become bicarbonate, or it could become the acid.
Right. So then once carbonic acid splits up, that extra hydrogen, all of it would be that renal component. I know we're not there yet, but all that together, the HCO3 plus the H is okay. Yeah. All right. Cool. That's all I needed.
All right, buddy. Yeah, you're almost there.
Instructor Morris.
Yes, sir.
So a pH of 7.32, is that neutral or is that acidosis?
Yeah. Anything less than 7.35 in the case of blood would be considered acidosis.
Would be considered acidosis. Could you explain to me acidosis one more time real quick?
Yeah.
Because I kind of understand it, but what would be neutral? Like, is 7 just the neutral?
Yeah. So, right. Well, you could think of 7 as neutral. That's correct. Most science classes will tell you that is neutral.
Mm-hmm.
Blood's case, it's neutral at 7.35 to 7.45.
Right.
So that is correct. So anything less than 7.35, like it technically, if you want to be technical, 7.34 would be considered, acidotic.
Got it.
But that that's a terrible example. Usually even in the hospital when we're checking, when we're looking at that, we're going to be like, okay, like 6.9. 6.9 would be, either respiratory acidosis or metabolic acidosis.
Okay. And so with the buffer system real quick, it doesn't add more base to the acid. It just breaks that acid down itself, right?
I
So
would
like,
like to say yes.
okay, so it just helps
It does both, actually. If you want to look at it that way, as breaking down the acid by removing a hydrogen, that's fine.
Okay, yeah.
But when you remove a hydrogen, what you're making is bicarbonate, which in theory reduces acid.
Okay. All right, I understand.
Yeah, I mean, you got it. I mean, you're right where you need to be. So if I add a hydrogen, I am getting carbonic acid. If I take a hydrogen away, I'm getting a buffer called bicarbonate.
Okay.
Perfect. You went down that way. Your father. I promise I did. Your room in the locker.
No, it was outside.
Oh.
It was outside of your door, I think it was. And I wanted to go get out, so I heard it just going through wires, and it went. And I was don't you do?
Jeff, why don't you move?
Oh,
I mean, the next day, did you say anything about the mom? Well, I don't know why all of a sudden now things are happening that never happened before.
They must have went blue coat pants.
It wouldn't make it all the way to 100.
And this time was mistaken.
Right.
I'm pretty sure I was wrong. Or if that, because I heard something. I went, yeah. It wasn't last night.
I did, they're good. I like those.
Guys, a couple.
Yeah. Those cookies. Those cookies are good.
Want some? You want some? You know, I'll whoop you.
You're really making sure it's a minute break, huh?
6 more minutes.
Come on. Come on, what you got? Come on, man, what you got? Oh, I'm the champion. Still the champion. Come on, Elijah. Okay, I surrender. I surrender. Oh.
Really? The block come out of nowhere. Mhm.
Sorry for all the.
I gotta get ready for these guys. Oh, man. Let's see here.
All right, let's go back to work. That's right. Still the champion, Elijah. Mhm.
4 more minutes. My knee.
I'm a winner.
All righty, we're back, I think. Let's see. All right. So where were we? We were fixing to talk about the kidneys, I think, right? So let me write this back up here real quick. Okay. All right. So we talked about the respiratory component, CO2 plus H2O. Okay. Because of the process of expelling CO2 and, so that would be the respiratory component. We talked about the circulating bicarb buffer, and it's all about this hydrogen being a weak acid and being able to give up on hydrogen easily. So it's either you're either having, in this case, you either have carbonic acid or you have bicarbonate. And then we have the renal component, right? So we have H plus HCO3. And the reason why it's written this way is because the kidneys can actually, remember, the kidneys are a filter. They're, man, alive. Filtration system here. And so it can actually excrete hydrogen ions. It can actually get rid of it, right? Or it can hold bicarb back and recirculate just bicarb. Well, and that's awesome. And that sounds great. But there is a problem, not a problem, but there's something that we need to talk about. Is how fast can all of this work? So the fastest way the body can either rid itself of acid or make acid to make something more acidic is through the circulating bicarb buffer. This is the fastest. Okay. The second fastest, that don't even sound like right English. The second fastest. But this will be the second, is through the respiratory component, either expelling. Oh, hang on, somebody got kicked out. All right, hang on one second. How do I do this? No, not that. Okay, we got a mod back. All right. So either expelling CO2 or, not expelling, holding CO2 through the respiratory pattern. So we're either going to breathe slow, right? This would be slow, or we're going to breathe fast. But this would be your second fastest way. So this would occur within minutes. All right. This happens right away. But the kidneys, the problem here, even though they're the best, probably the best at it, minus the circulating bicarb buffer. But the problem here is that they're very slow to respond, usually days.
Sir, I missed that. Missed what you said. These are the fastest and the second fastest way to do what?
To control, either to control acid or to provide more of a buffer. So your blood circulating bicarb buffer is the fastest. In second place, within minutes, would be respiratory. But the slowest by far, because it usually takes a day or days, is going to be your kidneys. And so that's why, you know, it takes a while to control that. So
what is the benefit to going through the kidneys if it's obviously insanely slow?
well, if we can maintain them, then the benefit would be huge because it can actually get rid of the hydrogen ion by excreting it. So it can actually pee off acid.
Okay.
So that would, but it takes a day or so. So what I'm saying is, if you have somebody who's hypoxic, you're not going to get the benefit of fixing acidosis through the kidneys. You're going to have to fix it either by increasing respirations to blow CO2 off, or doing something to affect the bicarb buffer.
Got it.
Okay.
And that's where IV treatment comes in. It's the fastest.
Absolutely.
Mhm.
Absolutely. So let's talk then about how acidosis affects the cell. Let's talk about that. So we talked about acid, and we always will represent acid by hydrogen ion. So let's say this patient is either suffering from a metabolic condition that would increase the hydrogen ion, or even a respiratory condition that would increase the hydrogen ion. So at the cellular level, all right, at the cellular level, we have ions as well. And the one that loves to live inside the cell, Instructor Lillard, I think, taught you guys this. What's the preferred ion that always loves to stay inside the cell? You guys remember? We're going to cover it in chapter 8, but
Potassium.
Potassium. And so we represent potassium by K. So we got potassium who lives in here. Okay. And hang on, let's see. Okay. And then
Sodium, right?
what's that? Sodium. Yeah, sodium lives outside the cell. So we'll throw a little sodium in here too. All right, so we have sodium that lives out in the extracellular fluid. Okay, so remember that this is intracellular fluid. Okay, and remember that this out here is known as extracellular fluid. Okay. And so potassium likes to, hang out there. Sodium's on the outside. Somebody might be trying to get in. Hang on one second. I hear it beeping here. No, everybody's good. All right. And so who holds the door open and in the school theory, who holds the door open so that potassium can come outside and sodium can come inside? Do y'all remember?
Cell membrane.
Proteins.
it would be an ion.
The door open. ATP.
The ATP?
No, it's
No.
okay. We're going to cover it in chapter 8. So that would be calcium. And so what it does is when potassium leaves, calcium helps to open that door so that potassium can leave and sodium can come in. All right. And we're going to talk about it in chapter 8. So you don't have to like get all crazy about that, but I want you to understand what happens to the body when it becomes acidotic. All right. So the hydrogen ion kind of rules everything. It's stronger than potassium and it's stronger than calcium. And so it wants to come inside the cell because of a couple of reasons. One, there's no hydrogen in there, and that makes it want to be there. And when it gets there, it wants to be popular. So it's going to come inside the cell. Well, there's not enough room for everybody to hang out. Okay, there's just not enough room for that. So what's going to end up happening is it's going to start kicking out potassium. Okay, it's going to start kicking out potassium. And then what do you think it's going to start kicking out after it kicks out potassium?
Calcium.
Calcium. Yeah. So then the next thing is it's going to start kicking out the calcium. That's a problem. Okay, so that's a problem. So when we do blood test, okay, when we do blood test, we're going to check this person's chemistries, right? We're going to look at their calcium. We're going to look at their potassium, their sodium levels. And when something gets kicked out of the cell, it gets kicked out here to the extracellular fluid. And that's really what we're testing. When we do those tests, we're not checking for what's inside the cell. We're checking for what's outside the cell. And if we have a bunch of potassium that's been kicked out, we're going to see that. And that has a name. So if we have a lot of potassium, does anybody know what that name is?
Ketoacidosis?
No, we could try. That's called hyperkalemia. Okay, and so I misspelled it because this is kind of how I abbreviate it sometimes. You can call it hyper K for hyperkalemia, and that's just, I'm gonna call it hyper K for now. All right, so hyperkalemia. All right, well, the same thing here for the calcium. We'll see a bunch of calcium there too, and that has a name. And it's hyper. What do you think the rest of it is called?
Hypercalcium.
Calcium.
Yeah, hypercalcemia.
Calcium.
All right, and so okay, so but the problem comes in to when we start looking at what their functions are. All right, so potassium, what it does for the cell, and you really see this when we talk about the sodium potassium pump. Do you guys remember what potassium kind of does? So what it does is it works with the speed of conduction. Okay. And when you know, conduction, speed of conduction or impulses. Of muscle contraction. All right. And so then if we look at hypercalcemia and what it does. So what it kind of does is it makes the nerve like hypersensitive. It increases something called neural transmission. So let me take you back now to the heart. And remember, we talked about the pacemaker of the heart. And I already heard somebody say it. We got the sinus atrium node. And what about this node down here? What's it called?
NA node?
The AV node?
AV node, I'm sorry.
That's okay. We got the AV node. All right. And what about these things that kind of go around the ventricles?
Purkinje fibers.
Yeah, Purkinje fibers. All right. And so when we're talking about this, if we look at the role of potassium, it controls the speed or conduction of these impulses, right? And so 80 to 100 is kind of the number here for the SA node. So it's going to mess with that, right? So the patient could possibly become bradycardic. Okay, slow. All right. Now, what about the calcium? Well, the calcium is going to make these guys something called hypersensitive. And it could possibly increase the neural transmission. So basically what that's saying is that it can make this system very, very irritable. All right. And so at the end of the day, what this can cause, instead of these impulses going down the SA node to the AV node, you know, stimulating contraction, it could cause a bunch of confusion. Into a rhythm called VFib, right? And if VFib's not corrected, we have something called asystole. A without, systole, contraction, referring to the ventricles. So if the ventricles aren't contracting, is the heart pumping?
No.
It's not. So it would be fair to say death, right? That's why acidosis is such a big deal, because it will basically destroy your sodium potassium pump. Does that make sense? All right. And so let's recap. Let's recap. All right, so CO2, all right, plus H2O is our respiratory component, right? So we talked about how that works. So I do kind of want to visit one other thing real quick while we're talking about this stuff, so that maybe you guys can see a clear picture. Oh, go ahead. This is a lot harder than I ever thought it would be here. All right. So basically, right. So let's talk about these blood vessels down here. I apologize for the drawing. So I have blood vessels, or I'm sorry, blood cells. All right. And so we know down here that we've got our cells here. And we know that we're going to want this guy's O2 at the cellular level. And we're going to give him that dirty, dirty, dirty CO2. All right. All right. So when we talk about at the respiratory side of things, okay, on the respiratory side. So, and we've talked about how we get rid of that CO2, right? And we said, well, you know, you breathe it out and that reduces acid. And it does. So let's put a number with it. So 23% of CO2, and I'm not going to, this is not like, you don't have to like, not testing you on the percentages here. Just trying to help you maybe see it. 23% of CO2 will be expelled by respiratory, of just breathing it out. So, okay, sure, Morris, what about the other part of it, right? So when we give up this CO2 right here, see, it goes into this red blood cell, right? But it doesn't all go into the red blood cell. Okay, it doesn't all go into the red blood cell. So if I'm giving up the CO2, it comes in here to the red blood cell, but it can't carry all of it to the lungs because that's the 23% that's going up here to the lungs. So it's going to mix with the blood. So CO2 is going to mix with the blood, mixes in the blood. And we said that blood is mostly water. Which is represented by H2O. And so 70% of CO2 will come out here and mix with this blood to make H2CO3, the buffer.
You guys mind muting your microphone if you're not talking?
Let's see, I could probably mute everybody. Let's see. All right, everybody's muted. So if you want to say something, you have to unmute. Hey, Suda, try unmuting. I want to see if it, make sure you can.
Yeah, it works.
All right, good. All right, cool. So let's look at this. So 23% that's going to go to the lungs is going to mix in here. 70%, I'm sorry, yeah, 70% is going to mix in the blood. So pretty cool, right? 70% of that CO2 mixes to make a buffer. And then the rest kind of gets dissolved in the plasma, whatever. But that's how you get that respiratory component, that 23%. For the component of the circulatory bicarb buffer, that's your down here, that's your 70%. And then the rest kind of either goes through the kidneys maybe, or just kind of gets dissolved. And there is a explanation, but I don't want to go there. It's too deep. So hopefully that will help you to kind of get it, right? And it's just, and don't get plugged in on this being carbonic acid, because it might be carbonic acid, right? But this hydrogen falls off so easily that it could be bicarbonate just as easy.
So 70% gets mixed into the blood,
That is correct.
and then the 23% gets mixed into
The blood cells that end up traveling back up to the alveoli. Remember, we
Thank
got the alveoli here. And so that 23% will get exhaled. Does that fix you up, Bloom?
Yes, sir.
All right, good. Does that, hopefully that brings it home a little bit, because you can see CO2 comes out of the cell. Sorry, yeah, out of the cell into the blood cell. Okay. Mixes with blood, which is mostly water, CO2 plus H2O. Okay. Comes up here, 23% of it gets exhaled, right? 70% makes the circulatory bicarb buffer, because once you have CO2 plus H2O, you get H2CO3. But again, don't focus on that being an acid, because the hydrogen's so easily to lose. It could be bicarb as well. Fast forward now to the renal function. We keep it there, even though you can't see it so much, but we know that the kidneys are a big filter, right? And we know that through a bunch of other things going on, the brain's going to be sending messages to either one or two things, either hold bicarb or get rid of hydrogen. And that's it. That really is it. And so then all you got to do is understand, and you already know this from EMT school, how do we rid our body of acid? Well, this is new, but expelling CO2 is not new. You know, expelling CO2 is something you guys already knew. You're like, the body's got to breathe faster to get rid of CO2. All right, cool. So then we talked about respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. So let's look then, let's say, okay, so you know if your patient's suffering from asthma, COPD, anything respiratory disease related, then you're going to be dealing with respiratory acidosis. If your patient is hyperventilating, right, from a respiratory condition, well, you're going to have respiratory alkalosis. Let's flip over now and talk about the metabolic part. And metabolic, I just think medical. What are some medical reasons? Well, we already talked about a big one. Is diabetes. Okay. Diabetics. Why? Well, because when glucose can't get into the cell, right, through glycolysis, if I don't have oxygen in the cell, or if I don't have glucose in the cell, then pyruvic acid changes to lactic acid, right? And that lactic acid produces hydrogen ions. So, okay, well, I showed you at the cellular level what happens. Hydrogen ions are going to rush into the cell, and it's going to cause the patient to be either hyperkalemic, right, or hypercalcemic, right? And so patients breathing fine, other than you'll notice that patient's respiratory rate will be faster, because the body's very intelligent. The brain's picking up on this acid, and it's going, okay, well, let me start, fixing this the best I can. So the brain's the chemoreceptor set off the alarm. The respiratory center of the brain says, let's start breathing faster. Okay. So even though it's not, hang on. Oh, it's just chats. Even though it's not it's not respiratory related, okay, but it's medically related. Now, when we get over to when we're talking about somebody who is metabolically hyperkalemic. Well, that's a problem for me to come up with a good diagnosis of why. There's several out there, but my God, their pathology is just, it's a mess. So I wouldn't really worry myself too much with metabolic alkalosis. Okay, just wouldn't. Hang on, let me look at the chats here. If you guys have questions and you want to throw it in there in the chat, you can. Okay. Yeah. All right. So, what's the end game, right? And how do we fix it? Okay. And so, how we fix it? Well, with respiratory is our biggest concern. Respiratory acidosis, right? Because we can fix that. So what would the treatment be? So let's go there. Let's go there. I'm gonna put the chat down here. I'm sorry, Maze, I missed you, buddy. I didn't know the chat was going on. So my bad. All right, so let's talk about it. How do we fix it? Let me get us some room. So respiratory acidosis, pretty simple, really. We fix the hypoxia that's causing it. And so we fix that, through airway management. All right. And so, whether it be from the asthma. So if the patient has an asthma, we have bronchial constriction. What's the medication we can give to fix that?
Albuterol.
Okay.
Albuterol.
Yes, sir.
Atrophy.
Albuterol, Atrovent. Okay.
Albuterol.
And so what's the dosage of albuterol?
2.5.
2.5 milligrams. What about Atrovent?
0.5.
5.
Okay. Because this right here is a bronchial dilator. Good job. All right. So yeah. So take something like asthma. All right. And so what about allergic reactions? Because that can cause through the reaction, we can have bronchial constriction, right? And so we can fix that with the same dosage. But what do we do to stop the bronchial constriction and allergic reaction?
Using epinephrine.
Epinephrine, right? So what's the dosage of epi?
0.3.
0.3 milligrams to 0.5 milligrams. All right. Okay, so that will fix those things, right? And something else now that we're going to start talking about a lot and is going to be IV fluids. So if we have somebody who has metabolic acidosis, all right, so if you look at that cell again, we have that hydrogen ions kicking out calcium. They're kicking out potassium, right? And so this patient is going to, at the end of the day, we're going to talk about it in diabetic emergencies too, because we're going to see there's always a little bit of extra in these medical conditions that they're going to give you. And diabetes, we're going to talk about it then, but this patient, if they're acidotic, we're going to call it ketoacidosis. They're going to be extremely dehydrated, right? So we can help fix some of the acidosis, not by much, but a little bit, by giving a sodium chloride bolus. Okay. And so we're going to talk about when we get to the pharmacy chapter, but you're going to give 20 milliliters per kilogram of body weight. And so what you would do is you're going to take 180 pounds and convert it to kilograms. Sounds hard, but it's really not, because you're going to divide that by 2.2. Okay, so you'll end up at the end of the day with 90 kilograms would equal 180 pounds. And so you would just take your 20 milliliters, multiply it by 90, bam, get your answer. Right, and so that's what you're going to end up bolusing. I think it's 2,900 milliliters. And so I'm sorry to be giving you all the pharmacology lesson now, but there's usually 1,000 milliliters per bag, right? So it's almost 3 bags of saline, right? So that's something we can do. So at the end of the day, we can do stuff like that. And then a paramedic can kind of get there and do a couple other things. A paramedic may, if the only time we'll do this, if there's EKG changes, like if I can tell the patient's so acidotic that their cardiac rhythm is starting to kind of get in a bad place, I might give them some bicarb, right, to start helping that acidotic state. Inside the hospital, these folks are train wrecks. And these are the ones that we have 3 IV pumps on, 5 different IV meds going. And, Instructor Morris loves it. I love a good ketoacidosis patient, because we can be slinging drugs, just in there slinging them. All right, so that's one way of treating respiratory acidosis.
We just hit 45.
What's that?
We just hit 45.
Man, a lot of it goes so quick. Okay, let's take another 15-minute break, and then we will finish up the acidosis, talking about treatment and things like that. Okay. Let me put the clock back on. Oh, wrong one. Oh, what's up? What are you doing? What'd you drop up there?
Instructor.
Yeah.
Yeah, that does. I think that probably would help other people too. I think, because I think we understand what this is, but like, how do we apply it? I think is where the problem's coming in. And then that second question I asked you, does that make sense to you?
Let me look at it again. It does. So yeah. So it's just something that you're going to assume if you have a patient who's like having an asthma attack or COPD, bronchitis, whatever, they're in moderate to severe distress. It's something you're going to assume that they're going to be acidotic to a state.
Okay.
Right. We don't know how bad, but yeah. And you can also pretty much guaranteed a diabetic patient who has a blood sugar of greater than 600, who's presenting, like a train wreck to you, is probably very much acidotic. Those are just because we can't draw a blood gas in the field to determine, right, if they're acidotic. But they want you to assume that the patient is. Because why? Because it's the worst case scenario, right? Worst case scenario for this diabetic patient is for them to be very acidotic, because then not only do we have to worry about the fact that we got cells dying, but the sodium potassium pump's not going to be working right. And we got to watch out for those lethal rhythms that's caused from that. And so, yeah, so they want you to think, all right, so metabolically, this is my worst case scenario, so that you'll be prepared to treat a upcoming cardiac arrest. You know what I mean? Used to, back in the day, people look at this patient like, and go, hey, this guy, I bet this guy's going to arrest. Well, and they would. Well, they want you to understand the pathophysiology of why this patient arrested. They arrested because they were so acidotic, and secondary to being hyperkalemic or, having, hypercalcemia with that they arrested because the sodium potassium pump failed to work. The SA node, AV node decided to not work correctly. A lethal rhythm occurred. Bam, your patient's dead. That makes sense?
Yeah, that makes a whole lot more sense, where it's not like your patient's in respiratory acidosis. What the heck does that mean? It's
right.
more, oh no, okay, that makes more sense. He's having an asthma attack. This is the underlying problem of what's going on.
Right. And so if we don't correct the asthma attack, that's the road you're going to go down. That's a road that you're going to go down, and you don't want that road, obviously. So yeah, so that's why and it's kind of cool in a way, because once you get a little bit, a little bit more experience in the field, and you can kind of enjoy the call because you're not so stressed, your mind can wander down that road. And I see it in my head. In my head, when I get a patient at the hospital that comes in, diabetic, I can see in my head that hydrogen's going in to that cell, and it's kicking out potassium and it's kicking out calcium. And so when I go to pull the drugs, I get insulin, and believe it or not, don't want to confuse anybody, we get D50 as well, and something called calcium gluconate. And we'll give the insulin followed by an amp of D50. And you're like, well, their sugar's 600. Right. But if we draw out, if we give that just the insulin, we'll end up drawing out more potassium, and that would possibly kill them. So we give them sugar so that insulin doesn't pull out too much potassium. And then we give them calcium gluconate to help replenish the calcium. And all of that drives the potassium back into the cell. And so once you have time to relax in the field, you can see that in your head happening, and take that with physical signs and symptoms. And this job becomes fascinating to watch that in my head. I can see it at a cell level, but to watch me correct it, and I can look at the physical symptoms start, becoming less severe. And that's awesome.
So like that example you just gave of the diabetic that's got 600 sugar, you can't give that insulin at first, because if you think about it with the cell, you're just going to overload that cell and you're just going to kill them eventually. So that sugar you give them at first is that buffer that helps try to balance things out before you give your insulin.
Right. And so what you have to do, the order of giving the drugs makes a difference. So we give insulin first, and then as soon as I give it, I grab my D50 and I push it right behind the insulin. And then I give the calcium last. And what happens is all of that process stops the potassium from what little bit of potassium I have left in the cell, stops it from coming out, and starts driving that potassium I have out in that extracellular fluid, starts driving it back inside the cell, returning the cells to a more normal state. And yeah, so if we didn't, you're right, we didn't give that sugar, at the end of the day, what would happen would be that while the immediate response ends up dragging more potassium out of the cell for some, big reason why, but it does. And I might be taking that last little bit of potassium that I had left going for me away. And now I'm dealing with somebody in VFib. And so it could be a bad day. So yeah, that's what I love that though. I do. But I didn't start loving that. I didn't love it learning about it in school. I didn't love it when I first got out in the field. It was a while before I was able to put that into practice, before I was able to not be tunnel vision and scared to death and be able to really see it for what it was. And then after that, I was hooked.
Mind if I ask you something?
No, go ahead.
So if when you pee, your kidneys are getting rid of acid.
It can, yes.
Right. Or it can hold back bicarb. But
Correct.
so if you're in diabetic ketoacidosis, you're going to be peeing a lot, and there's going to be a lot of sugar coming out too.
Absolutely.
If you're peeing a lot, wouldn't that mean that you're getting rid of a lot of acid? Why would you go into acidosis?
Right. But you can't really assume that you're gonna pee off a lot of acid, but you're going to try. But what ends up happening is there's more acid being created because acetyl CoA is a player in that. And what ends up happening is acetyl CoA, I'm trying to remember, it starts deteriorating. And what ends up happening is you start having an explosion of probably more acid than your body can metabolically deal with before you know what I mean?
Yep.
It just can't catch up.
I see.
And that's the problem with the kidneys too. They're a day or two late to the game. And so before they even get in the game.
Right.
And so that's a problem too. So I think that's one big reason. But the Kussmaul respirations,
yep,
it's all because of that. You're acidotic.
Right.
You're trying to blow off all that CO2, and your respiratory rate and pattern as you have those deep as you could get respirations. It's fast. And then there's that period of apnea where your body's resetting, going, okay, am I still acidotic? Yes, I am. It just keeps repeating.
Hey, Campbell.
I didn't hear all of it, but
Campbell's having playtime with his kid.
Oh, is he?
Yeah.
Good for him.
Are you gonna go my way?
Campbell, you forgot to unmute again.
Campbell, your singing voice is beautiful.
Mm-hmm.
Are you gonna go my way?
Filet.
This commercial is brought to you by Allstate. Are you in good hands?
He sounded like that guy too.
Nope.
Figure we might get some ads in while we wait.
All about Grim spins.
Are you challenging me to a fight, Grim?
Wait a minute, there was too many people talking. I want to say that again.
You challenging me to a fight?
Look here, my brother. I am a peaceful man. I do not fight. If you want to fight, you just look elsewhere. Okay.
You afraid because I'm gonna beat you?
My brother, the only thing you'll be beating is yourself. I'm only in competition with myself right now. All right. We learned about this ketoacidosis and all these little hydrogen ions and all this stuff going on. I'm not worried about fighting you, Luke. This next commercial is brought to you by Grim Spans.
Yeah, yeah.
Ooh, look at Bloom's background. He out the world. Hey, Maze.
Hello?
What's up going on, dog?
Oh, Grim, hello. Oh, well, you want to say hi on here, but you don't want to respond to my Snapchats? Okay.
Look, I don't know what y'all do in Colorado, but down here in Georgia, we do not Snapchat other men.
Me and JJ just talked, you idiot. Come on now.
Thanks for calling me out, man.
Campbell, did you have a good time playing with your kids this time?
Did y'all hear me again?
Yep. Yes, sir.
Yep.
Oh, man. We were playing
Maze,
rough.
stop Snapchatting me.
We were playing rough, and then he decided he didn't want to play rough anymore.
Is that what you call it?
Bloom was bored.
I'm watching him. I like that one.
Okay, so we're back. I just sent out a question, just ignored to why I did it, but kind of want to see where everybody's at. All right, so 83% of you guys voted. So almost there's 6 people who didn't. 56% are getting it, but they're not there yet. 40% of you guys say I'm getting it, and 4% of you guys are like, no, man, I don't have a clue. So that's where we're at. All right, let me get this new one here. All right, so this is kind of where we're at. So let's do something here. Okay. Years of age, male. Plain of an asthma attack. Okay, so he's had difficulty in breathing times 2 days. He's conscious and moderate to severe distress. So his vital signs are (142/88). His pulse rate is 90. He's breathing 30 breaths per minute. Pulse ox is going to be at 89% room air. Okay. Now then, so let's do this. What I want to know is this patient is suffering from what type of acidosis? And question number 2 is going to be, how can you reverse it? And so let me try to send a poll out real quick. Let's see here. All right, so let me put this in real quick.
Anyone else got the poll yet?
I hadn't sent it out yet. I'm typing it up now.
Okay. I was kind of getting a little concerned on my side. I was about to be like, oh shit, like, but yeah.
What does DIB stand for?
Difficulty in breathing. All right, let's see here. All right, it's coming to you now. All right, so 26 of you guys have voted. I got 27. $28, $29. Got one more person out there needs to vote. Somebody might have logged off or something. I don't know. All right, so I'm going to end this. I will tell you that 72% said respiratory acidosis, 14% said respiratory alkalosis, 14% said metabolic acidosis. How do you treat it? 83% said give oxygen, 14% said IV therapy, and 3% said place the patient in position of comfort. All right, so let's go back over here. All right. Okay, finally. All right. So let's take it back a little bit to glycolysis for a second. Got our glucose. We got our cell. So glucose comes into the cell. Okay, and so we know from our lesson the other day that we must have oxygen present for this glucose to be able to get into the mitochondria. Right? So if oxygen is not present, it's called anaerobic. Right? And so in this case of the patient who's suffering from an asthma attack, either there's either zero oxygen, right? Or the oxygen's not at the, not enough oxygen. And so it cannot make it into the mitochondria. It gets stopped. Right? And so in that case, we know that pyruvic acid converts over to lactic acid. All right, so we have this lactic acid now that's going to build up, right? And so lactic acid is a hydrogen ion. So in the case of the patient who is having an asthma attack, they're definitely going to be acidotic. Okay. So now we just need to decide, is it from a metabolic acidosis or is it from a respiratory acidosis? So we have a patient here with signs and symptoms of respiratory distress from, a disease process of asthma. So it's definitely going to be respiratory acidosis. Now, so that answers the first question. Okay. So the second question is, how do we treat it? And so what I did was I put a little trick in there, right? I said, O2 would be one choice. The second choice would be give IV fluids. And then that third choice was position of comfort. Well, so we know that this patient's having an asthma attack, so we're going to treat this patient. We're not just going to put them in a position of comfort and say good luck. So that's out. And I did say IV fluids will help, especially in metabolic acidosis. But in respiratory acidosis, the whole problem here is that, we don't have oxygen in the cell. So let's correct that hypoxia by doing the simplest thing. We start correcting hypoxia by providing O2. All right, that's our first thing, right? And so we're going to do one or two things. We're going to start this patient off on non-rebreather, 15 liters per minute, right? While we're getting our albuterol atrovent set up. Then we come along and say, okay, we're going to change this guy out now. We're going to put this patient on a nebulizer mask, at 8 to 10 liters per minute. And just underneath that, we're going to have our 2.5 milligrams of albuterol with our 0.5 milligrams of atrovent. Because this is a bronchial dilator, we know asthma, bronchial constriction. Let's start correcting the acidosis by dilating those bronchioles. Because once we start pushing O2 into this cell, glucose then can go into the mitochondria, right? And pyruvic acid will no longer be lactic acid, right? And there you go. So same thing here. When you look at respiratory acidosis, what do we have? So we have the respiratory component CO2 plus H2O gives us H2CO3. Now, this patient is suffering from respiratory acidosis from asthma. So this patient is having an asthma attack, respiratory acidosis. All right. What's going to happen here? Well, our carbonic acid is going to, this whole reaction is going to shift to the right. We're going to lose that hydrogen. So we're going to have hydrogen. Now we're going to have bicarb. Okay, so we're going to make that bicarb to work to help the respiratory acidosis. But if we don't correct the hypoxia portion, we will not be able to, this will not do it alone. Bicarb will not be able to fix this. It's going to help while we're getting ready, but it won't be able to fix it. We have to restore the respiratory tract. We have to open it up. This will continue to hang around while the patient is rebounding. So patient starts breathing better.
Jenkins's power just cut off. He's waiting for his power to come back on.
Okay. I think somebody just popped in. Hang on one second. Let me see.
Said his router, waiting for his router to reboot.
Okay. That's good. So, and by the way, I'm recording this, so it'll be on the site. If anybody gets disconnected, you can go watch it. So when the patient's breathing better, all right, we're still going to be a little bit acidotic. So this bicarb will hang out until everything's corrected. Once everything's corrected, it just shifts back and forth. So let's talk about this. Let's do another poll real quick. Let me throw something else out there. All right, hang on 1 second. Let me get him in here. Okay, I just threw one out there real quick. Waiting on 2 people. All right, waiting on 1.
Sorry, I had to do something real quick.
There we go. All right, so 73% said metabolic acidosis. All right, we had 7 folks said metabolic alkalosis. Got 1 person who said respiratory alkalosis. All right, so let's talk about it. All right, let's look at what's going on. All right. So we have glucose here. All right, and we have our cell here. So glucose wants to come into the cell, but there's a problem. Problem is that this cell right here has this little receptor. And it's for insulin to come along here and land in. So insulin unlocks the cell so that glucose can come into the cell. All right, well, the problem here is that insulin doesn't show up, right? So all right, so insulin tries to come along here, but it's missing. All right, so glucose is right here, but it can't get in, right? And so that glucose is out here in the extracellular fluid. So that's why when you do a finger stick, your glucose, it's gonna be high, like 550, or it just may say high on your results. All right, so if glucose can't get into the cell, we have the same problem we had earlier. Okay, so this pyruvic acid will now convert to lactic acid. All right, and so we will end up having an increase in hydrogen ions. So what you end up having back down here, and we can show it here, is what I talked about earlier. Hydrogen ions are going to force potassium out of the cell. All right, it's going to force calcium out of the cell. And so this patient's definitely going to be suffering from metabolic, I don't think I spelled that right, metabolic acidosis. Okay, and so and we can look at it. We know we have the increase in hydrogen ions, so we know we're going to be acidic. The patient's not suffering from a respiratory disease, such as, no asthma, right? We're not suffering from COPD, none of that. So respiratory is out. So it only leaves us with metabolic. So that's the reason why the patient's suffering from metabolic acidosis. So let's look at it. All right, so CO2 is H2O. gives us H2CO3. All right, and so definitely going to be going to the right here. We got to separate, got to take that hydrogen away, right? So we're left with that one hydrogen, CO3. We got bicarb. We got bicarb in the making. The body's first response is to create bicarb. The body's second response is to increase respirations. And the body's third response here, so the bicarb buffers happen first, respiratory happens second, and now third, the kidneys will try to get in the game, right? But they're 1 to 2 days out. So they're not going to help us right now. So the only thing that we can do in this case is let's treat the dehydration with some IV fluids. We're still going to give O2 probably. We're going to do all that, but we're going to start get IV fluids going here. All right, but the most important thing is to recognize that this patient is in metabolic acidosis, and so remember too what's going on with this pH scale. All right, so we got 1, 2, 3, 7, 15, right? We want to be like right here around 7.35, 7.45, right? But we're not going to be there because we're going to end up going this way. So we're probably going to be somewhere in the 6s or 5s. So we could be like 6.0. That's going to show that your patient is acidotic. So take it back to the cell and glycolysis and work your problems out like that. If you're ever missing glucose, you can't get into the mitochondria. If you're missing oxygen, you cannot get into the mitochondria. All right. That's anaerobic. Right. What are you going to get from that? Acid. Right. And, little ATP. So that's the kind of problems that, that you need to be working out at home. I think if you'll just study this a little more and think about it some more like that, you can get there. I will be back at 1 o'clock. I think I'm going to send out another link. I don't know. Suda said we might use the same link, and I'll explore that, but I can't explore it right this second. So I'll send out. Sorry.
You just mixed me up with Idson again. 2 days.
Suda said.
We have so much in common.
Okay.
Well, you know why I mixed you up? Because you're always confident, and Edson said it so confidently that I heard you.
Oh wow, that's really sweet.
Way to fix that, sir. Way to.
Intelligent people tend to be confident.
Don't.
Never fine.
What do you?
Be surprised how wrong you are in that statement.
Edson, that's 2.
Ruin the whole thing.
I know. All right, so I'll send out a new link. So those of you who are getting it, you don't want to come back at 1, you don't have to. Those of you who want to come back at 1 o'clock and work some more out, I'm glad to do that. So I'll be back here at 1. And if not, I will see you guys tomorrow morning at 9, and I'll send out the link for that as well.
Are the 1 o'clock sessions afterwards, are they live recorded as well for playback?
I thought about that yesterday. I didn't record it, and after I got done, I wished I had have. So I will record those, and I'll just note it as the 1 o'clock study session.
Sweet. And that's on those playbacks are on the learning website, right?
Yep. Yeah,
Okay.
I put it on there this morning or yesterday, and I'll put this one on in just a few minutes.
Okay, perfect. Thank you, sir.
So just had
Don't come back at one. Try watching the Ninja Nerd videos. They are really helpful.
Well, thank you for kicking me in the ass. Ninja Nerd's better than Instructor Morris. So tell y'all what, 1 o'clock, the hell with Instructor Morris. No, I'm gonna be honest with you, he is great. He is really good. But the only problem is with Ninja Nerd is that he's deep. He's way deep. And you don't necessarily need to get that deep, but that may help you to go deeper. So to understand it more. I don't know. But but yeah. Jones is right. He's good. He's real good.
I just had one question. As far as the like the blood sugar level, like would it being like so high? So if it was like on the lower side, it would have been alkalosis?
No, you can still suffer from acidosis either being high or low, because the problem is either you got so much sugar that you can't use it, or on the other end, you've got so much insulin that's opening all the sugar gates that you don't have enough sugar to make it work. So irregardless, if you've got all this sugar that you can't use, you're going to be acidotic, or you have zero sugar because insulin's are, made it to where you don't have any, and you have zero sugar, you can still suffer acidosis from either one. Irregardless if it's 0 or 600, sugar is not able to get into the cell to mix with O2 to, have that reaction. Does that make sense?
A little bit.
Well, the reason why I have so much sugar out here, all right, I have let's say, 850. I have a sugar of 850 because it cannot get into that cell. Insulin did not show up here to let it in. So it's all outside the cell. But if I have too much insulin, then I don't have enough sugar to go into all of these cells at once. So I have all this insulin opening up every cell around to get glucose. And so instead of 850, now let's say I have 10. It's the same concept. I don't have enough sugar. So therefore, when we're talking about getting into the cell, I don't have enough sugar to go around. So therefore, there's no sugar getting in the cell. So if I take it to glycolysis and we look at it, glucose can't get into the cell, right? And so what's produced? Well, we have pyruvic acid that changes to lactic acid that at the end of the day produces more hydrogen ions, and we're acidotic. So it's 850 here is unusable sugar, and over here, not enough sugar. It's like putting diesel fuel in your gas tank. It won't work. It's still gas to a lot of people, but it's not the exact right type of gas. So if I put that into my car, it won't work in the carburetor. But if I run out of gas, well, I don't have any gas to go in the carburetor. Either way, I got a problem.
Okay. So what's the instance of it being alkalosis then?
Great. So alkalosis wouldn't have a diabetic scenario. Sorry. It would not have alkalosis definitely would not have a diabetic scenario. It would definitely have to be something else. It would look like this. It would Let me come up
Well-
here with this.
What about in the case of somebody with low blood sugar? Like, would they go through alkalosis or would they still go through acidosis?
That's what I was just talking about.
Okay.
If their sugar's low, then there's not enough to make it into the cell. So we're not, let's say it's 20. Well, 20 is not enough to power the cell. If it's 850, then it's not making it to the cell because insulin did not show up to open the cell up. So either way, I have no sugar, 0, making it into the cell. I had to have glucose and oxygen to go into the mitochondria. If I don't have glucose or I don't have oxygen, I'm going to end up getting hydrogen, which is acid. Maybe back up to answer the question about alkalosis real quick. If, let's say the scenario is this. Let's say the scenario is an overdose on a medication. So let's say you have an overdose on medication. We're going to call it medication X. Okay, medication X. And what medication X does, if you take too much of it, then it's going to cause you to have respiratory alkalosis. It's going to increase your respiratory rate so much that you're breathing off CO2. All right, so this reduces the amount of CO2 in the blood. Okay, so it reduces the amount of CO2 in the blood. So let's look at then what happens to our reaction. All right, so CO2 plus H2O gives us H2CO3. Oh, crap. H2CO3, which we know is the buffer, right? All right, and so the buffer system, right? So in this case, the reaction, instead of going to the right, will now go to the left. Because right now, what we have is too much bicarb, and we need carbonic acid. So the reaction now will go to the left to create carbonic acid. Right. And so that's what's going to happen if we're alkalotic, because we're going to have a pH. Okay. So right here is 7.0. We'll call this 15. We'll call this 3. Give me 3, 15. All right. And so let's say this patient gets to the hospital and has a pH of 9.8. So obviously they're alkalotic. And so we have carbonic acid being made. The body will compensate. Instead of increasing respirations, it's going to hold back, slow down respirations, because we need CO2 to help make acid. Okay, so that would be like a scenario for alkalosis.
Respiratory alkalosis, not metabolic.
No, that would be like if the patient overdosed on a medication, then that would be more of a metabolic.
Okay.
If you want a scenario for respiratory metabolic acidosis, then instead of that it would be, 45 years of age, male, complaints of tingling, numbness in the hands and face. Patient tells you that their girlfriend left them. Patient has a history of anxiety. Okay. And so I would say that you get there, the respiratory rate is 48, pulse rate 128, I'll call 120, and blood pressure going to be good. It's going to be like 128, 70. It's SAT's going to be 100%. All right. So what's the problem here? Well, this problem here then is that we have respiratory alkalosis because we're breathing off all of our CO2. Okay. So we're breathing off all of our CO2. And so this reaction will still go to the left because without CO2, we don't have, then we have too much bicarb because we don't have CO2, right? And CO2 makes acid, so we don't have enough. So the body's going to try to compensate, make some carbonic acid. Does that make sense?
Yeah.
All right. So I will send out the links. And for those of you guys who want to come back at 1 o'clock, come on back.
Don't delete this yet. I'm trying to write it down.
Okay. Just tell me when. Everybody good? All right, guys. I'll see you at 1 o'clock if y'all coming back. Bye-bye.
Bye.